Good evening, everyone. My name is Ben, and I'm here on behalf of the Hospital Research Foundation Group Arthritis. And I'd really like to thank everyone for joining us tonight for another one of our arthritis webinars. Now, first and foremost, we'd like to start with an acknowledgement of country. I'd like to pay my respects to the traditional custodians of the lands across South Australia and pay my respects to elders past and present. Now, this webinar has been made possible through funding from the Country South Australian Primary Health Network. And I'd like to raise that we have questions and answers, and that's open during the entire time. So if something during the presentation tonight, tickles your fancy or you want to ask something, just pop that in and we'll get to them at the end. Now, tonight's a really interesting one for us. The webinar is titled Sleep and Pain. What is sleep? What can help and what could work for me? And our presenter is Associate Professor Amy Reynolds. Now, Amy is an Associate Professor in Clinical Sleep Health at the Flinders Health and Medical Research Institute. And she's a provisionally registered psychologist who works in insomnia treatment, including with patients living with chronic conditions. Amy has a lived experience as well, as she has an autoimmune disease herself. So I'll hand over to you, Amy, and thank you very much.
Thanks, Ben. It's great to join everybody in the evening. And thank you so much for having me. Just want to very quickly just add to your acknowledgement of country, Ben. I have the privilege of sitting at the Adelaide Institute for Sleep Health, and we are located right next to a significant site called Warraparinga, which is a culturally significant site for the Kaurna people, and we're privileged to be here and work on these lands. So as Ben mentioned, I'm Amy. I have the privilege tonight of talking to you about two topics that are important to me. So by trade, I work in sleep. I do quite a bit of work with shift workers in particular, and do a whole range of things looking at how shift work and sleep disorders impact health, safety, and productivity. I'm also an epidemiologist, so I have done quite a lot of work with larger samples of data looking at what happens for sleep in the community. And some of the information I'll show you tonight is about sleep in the Australian community from a study that we ran with the Sleep Health Foundation in the last couple of years. So I get to talk about sleep a lot. I also love to sleep. I'm the kind of person that goes to bed early and gets up early. So this is starting to get close to my bedtime. But it's always nice to try and see what's happening at the other end of the day. And the other thing I get to talk to you a little bit more about is perhaps one that I'm less sort of thrilled about having, but something that I live with too, and that's pain. So as Ben mentioned, I have the pleasure of being a patient partner in a range of research studies, and that's because I have lupus and antiphospholipid syndrome. And one of the big challenges for me on a personal level is I struggle with arthritis. It's one of the symptoms that probably gives me the most grief on a day-to-day basis when my condition is not well controlled. So I'll be predominantly speaking to you about sleep from a professional experience, but also some little personal experiences will almost certainly pop up as we go along too. So for tonight, I thought we would cover some broader information about sleep and normal sleep. One of the things we know when we work, particularly with people that live with insomnia or sleep disturbance more broadly, is that what we think we know about sleep and what's actually true about sleep can be two very different things. And so I'll cover a little bit about that and a little bit about changes with age and changes, natural changes in our sleep as well. I'll also go into a little bit more information about what poor sleep looks like and how different that can actually be in terms of how it affects our daily functioning for people. And, the experience of not getting enough sleep looks quite different from person to person. And also some more specific stuff about what sleep is actually like for people living with arthritis. Certainly, we see people in our insomnia clinic that live with arthritis or chronic pain. And the reassuring, maybe a bit of a spoiler alert, but the reassuring thing is that some of the treatments that we do know work for insomnia can be really effective for people living with arthritis. We'll go over some sort of very high level ways to improve sleep or think about sleep more broadly. So not just if you have a sleep disorder, but also more broadly if sleep, could be better, but doesn't necessarily meet some of those criteria for a sleep disorder. And I'll cover a bunch of resources that are more publicly available that you can tap into freely online as well. And finally, I'm going to aim to allow as much time as possible for questions, because usually when it comes to sleep, everybody's got one. We all sleep or we all don't sleep, depending on the audience that we have. And, wherever we can, we try and answer questions more broadly. So before I start, and one of the great things about online webinars is that we do have the opportunity to ask questions virtually as we go and use sort of chat functions to ask questions. So we'll come back to as many of these questions as we can at the end, but feel free to just jump into that chat and note down any questions or problems about sleep that you've come to get answers to. Usually my goal is that ideally I'll tick a few of them off as we go along, and that's always nice. But most importantly, it means that if there's a question that you've kind of walked in this evening virtually to hear about, I'd love to be able to make sure we can come back to that at the end. So please feel free, like I said, to jump into that chat and ask some questions now. That's fine. And we'll come through to them at the end of the session, or make sure we've covered off on what was really interesting for you or what you wanted to know. So this idea of normal sleep, or the ideal sleep, is a really interesting concept, because in many respects, we tell our children, the conversation we have is about this idea of going to bed, having a good sleep, and then waking up and feeling better in the morning. I know I'm probably guilty of it too with my children. I say, all you need is a good night's sleep and this will feel better in the morning, or you'll be able to think about this differently in the morning. But in a way, the conversation that we have about sleep and what good or normal sleep is something we need to think really clearly about, because for many people, what feels like what should be good or normal sleep is actually quite different to the reality. So a bunch of Australian researchers, for example, asked people to draw on a graph what they thought normal sleep looked like. And most people, I think it's about 70% of people surveyed, draw sleep like this. So just to give you a bit of information about the graph that we have here, across the bottom, so this bit along the bottom where we see 0 to 8 is the amount of time from your bedtime. So lots of people associate getting enough sleep or good sleep with getting 8 hours a night. Whether that's true for everybody or not is something we can unpack in a minute. But what we also see on this left-hand side is moving from being awake into some lighter sleep or some dreaming sleep, and then, into slightly deeper sleep, with stage 3 being this very deep sleep. And most people think that our sleep pattern should look like this, that you should get into bed and pretty quickly you should start off in light sleep, go off into some very deep sleep, get that deep sleep that everyone tells you is really important for feeling well, and that you gradually come back up towards being awake after a nice solid 8 hours of what's predominantly deep sleep. And actually, the reality is that that's not what normal or healthy sleep looks like. In many respects, it's actually not healthy for us to go to sleep and then not have any awakenings overnight. And this usually comes as a little bit of a surprise for many people, because what our sleep actually looks like and what healthy sleep looks like is a little bit more of a roller coaster. So this is the same graph again. So along the bottom, you've got bedtime and then the number of hours that you've been asleep moving across the bottom. And again, we're going from being awake when you go off to bed and fall asleep all the way down into that deep sleep, which is what we call stage 3 sleep. In Sleep Well, we're very, very creative with our labels. So we go from stage 1 to stage 2 to stage 3. And then REM sleep is that rapid eye movement sleep or dreaming sleep. And so what we actually see is that our sleep happens in cycles. And the thing that usually surprises people is that it's extremely normal to wake up during the night and have brief awakenings and then go back off to sleep within, sort of 10 to 15 minutes. There's not anything wrong with your sleep if you wake up sporadically and get yourself back off to sleep. And there's probably an evolutionary reason that would be healthy, because particularly if we are responsible for making sure our environment's safe, then that's a really important part of being asleep. If we were vulnerable enough that we went to sleep and just slept deeply until we woke up 8 hours later, that would probably have some implications for humans and survival, particularly back in the day. So we know that this number of 8 hours, or getting between 7 to 9 hours of sleep, is commonly sort of thought of as the ideal sleep duration. The reality is that lots of people have various sleep needs. So some people will often find they need 9 or 10 hours. That 10's probably getting a bit higher on the level there as a healthy adult. But, you know, some people seem to need less. And one of the kind of rules of thumb, or if you like, or an easy way to sort of have a think about whether you're getting enough sleep is whether you need an alarm clock to wake up every day. So often that's one of the first questions that we ask is, do you need an alarm to wake up? Is it hard to wake up in the morning? And that can be a little bit of a test as to whether, well, you're getting enough sleep in that previous sleep period. So the other thing that we know is that in addition to this kind of roller coaster of sleep, moving through the cycles of sleep over the night, there's usually about 5 of these kind of dipping cycles over the night. Is in addition to that, we also know that people need this sleep at slightly different times. Sometimes you'll hear it referred to as night owls or an early bird. And what that actually reflects is something that we call chronotype. So some people do seem to do better if they can get up in the morning early and then go to bed early. I'm one of them. Other people seem to do better if they go to bed later at night, but then are able to sleep later into the day. And that would be my husband. So, you know, there are definitely examples where the people in our household can sort of work on different schedules and different timing for that ideal sleep. And again, that probably served a pretty important purpose. You know, we do need some people to be up early in the day, doing morning tasks and taking care of the community. Whereas, you know, we also need the evening types to be taking care of the nighttime watch and looking after evening activities. So it makes sense that we are all a little bit different in terms of when what we call our internal body clock works. So that's the clock that gives us, you know, that signal of whether we like to go to bed early or whether we're somebody that perhaps stays up a little bit later at night. So that's kind of the 2-minute version of what that looks like in terms of our body clocks, but just a reassurance as well that, you know, it can be very different. Some people can be, you know, prefer to stay up late at night and that works for them, and others can prefer to go to bed early. And those can be normal. There can be extreme versions of needing to go and get your sleep really early at night, or going to bed really late, so into the early hours of the morning and having trouble sleeping before then. And they're actually what we call circadian rhythm sleep disorders. And certainly one of them, the one where people go to bed quite late, so 2, 3, 4 o'clock in the morning and need to sleep later, can be quite disruptive when you're trying to get up to, you know, to go to work and fit in with society. So there are a range of different treatment options for people that have that what we call delayed sleep-wake phase disorder. So a very big name for saying they have a really late clock and seem to get their sleep, you know, sort of early in the morning, and then sleeping in later is ideal for people with those sort of later clocks. So the other thing that we know is that your sleep changes over as you age. So, for example, infants come out with very unclear sleep patterns. It takes them a little while to adjust to the day-night sleeping pattern, but that also, those changes in our sleep continue as we age. So you can see on this graph, we've got sort of 8 hours of sleep onset. That's kind of that rough rule of thumb, or the mean value of how much sleep people typically get per night. But as you get older, we see that people seem to need less sleep. So there's only that kind of 7 hours on that graph now. So 0 as bedtime and then up to 7 hours. And then with age, we also see more of those awakenings overnight. And again, what we're talking about here is what we would say healthy sleep. There seems to be more awakenings earlier in the night. It can become challenging or problematic for people if those wakings at night are more challenging to get back to sleep. And I'll cover that a little bit more in a little bit. But more that reassurance that actually as you age, it can be normal to wake up more during the night. And as long as you're able to get back off to sleep, you know, within sort of 10 to 15 minutes and it's not causing you distress, then absolutely that can be normal. So this is a bit of a, and this is where you'll realize how creative we are with our acronyms in our field. I'll talk you through some of these, but basically this is showing the change in the types of sleep that we get as we get older. So working from the left-hand side over to the right-hand side is increasing age. And each of those blocks of color represent a type of sleep. So in this, we've still got that stage 1 and 2. So those lighter sleeps are in green and sort of that orangey color. And then SWS simply means slow wave sleep, or that stage 3 sleep, and deep, it's that deep sort of restorative sleep that we hear a lot about. REM is that rapid eye movement sleep, so that dreaming sleep. And then wake after sleep onset is how much time we spend after we go awake, after we go to sleep. And so the big sort of changes that you see with aging in particular is that big chunk of purple that we see for particularly for children and adolescents, which is the deep sleep, starts to thin out over time, certainly as we age. And we also see, we saw those extra awakenings in the graph I showed you just before. That's what we're seeing here with that WASO, or that wake after sleep onset, is that as we age, we tend to report spending more time awake after we've tried to go off to sleep. So if you're somebody who has seen this and thought, I'm going because I don't get enough sleep, or I really worry about my sleep, or I feel a bit alone and I don't know what to do about my sleep. Some of the work that we did with the Sleep Health Foundation here in Australia back in 2020 helped us to get to the bottom of how much people in Australia sleep, and also how much things like our lives and the things we have to fit into the daytime impact our ability to sleep. And what we actually found is that nearly half of Australians that completed our survey tell us that their daily routine means they don't get enough time in bed to be able to get the sleep that they need. And that's really not an uncommon finding. So what we see is that it can get really tempting to start to fill up the daytime hours with everything that we need to do, whether it's getting our work done, whether it's supporting family, whether they be young children, older adults, or family members with additional caring needs. It's trying to get, the things that we enjoy in our hobbies, trying to get the recommended exercise that we're told we need. All of these things are bits that we try and squeeze into the day. And what we see is, because sleep isn't something you can multitask, you can't listen to a podcast and exercise. You can listen to a podcast and exercise at the same time, so you can combine hobbies. But the one thing we're pretty clear on is that sleep is a bit of an isolated activity. And so what we see then is that sleep seems to get squeezed out, and that seems to happen for almost half of our population. So, it means that for many people, there just isn't enough time in the day to get the sleep that they feel like they need. And what we see also is there are some common, what we call hallmarks of poor sleep. So whether it's difficulty falling asleep, waking up a lot during the night, or waking up really early and having trouble getting back to sleep, are the kind of 3 features that we look at when we start talking to people about insomnia. And the important sort of message here, and what you're seeing in this graph, is that people's age over time, so from 18 to 65 in the picture here. And what we see is that people can experience at least one of these sleep symptoms 3 or more times a week, relatively commonly. So disturbance to our sleep is not uncommon. In fact, there's actually, there was a parliamentary inquiry back in 2018, 2019, which found that there's a really pressing need to do something about sleep health in Australia. So this doesn't mean these people all have insomnia. That would be a frighteningly high statistic for what we call insomnia disorder. But what it is letting us know is that, from time to time, many people experience these symptoms of having trouble with their sleep. And if you think about it, it's probably not surprising. Things like stress can really impact our ability to get to sleep or stay asleep. If we've got a particularly busy time in our lives where we're trying to juggle, lots of competing demands on our time, that can really impact our sleep for some people. And also when you're living with things like chronic pain, we know that these are all things that can disturb our sleep and how well we get to sleep, or how hard it is or easy it is to stay asleep at night. So very high level kind of summary, and I'm going to include a couple of these snapshots throughout our webinar night, just and direct you to the Sleep Health Foundation, because these are Australian resources developed by Australian researchers. And some of the most common reasons people don't get enough sleep I've alluded to already. Sometimes we can take sleep for granted. We can sort of, one of the things that when we talk to young adults, for example, we do some research with young adults. And one of the things they tell us is they say, look, I know I'm not getting enough sleep. I know I need to get more sleep, but I don't want to compromise on everything else. So I need you to tell me how I can maximize the time. So I want to be able to go to sleep at this time and get up at this time. And that sleep needs to be amazing. And sometimes that kind of doesn't work. We can sort of push everything right up until the time we go to bed and really kind of fit it all in, and then end up in bed we've allowed ourselves just what we think is the right amount of time to get sleep, and find ourselves lying there still trying to wind down and thinking about the day and thinking about the things you didn't get done, and having not allowed the time to be able to be actually ready to go to sleep. The other one is too much caffeine, alcohol, and sleeping tablets. So one of the things we do know is that caffeine can stay in our blood for a really long time. It can have an effect on our alertness for a really long time. So many people do like having caffeine because it alerts us. It can make us feel more awake. But the consequence is that if you're somebody for whom caffeine stays in your body for longer, it can actually mean that if you're having tea or coffee or chocolate or any other sort of caffeine containing foods or drinks in the early afternoon or late afternoon, that can then actually still be impacting you when you try to go to sleep. The other one is alcohol. Sometimes people report having alcohol before bed because it helps them get off to sleep. And certainly that does seem to be the case for some people. But what we do know is that alcohol then disturbs or fragments the sleep that we have over the night afterwards. So it might help us get to sleep faster, but it doesn't necessarily help us to stay asleep and get refreshing sleep. Shift work, I'm a little biased. I think this is a particularly important one. We don't actually have to be a shift worker to be working or disrupting our body's clock, especially post-COVID. If you're someone that can work from home at any time of day, we can see that some of the behaviors that we would normally do during the day, because we're diurnal creatures, start to creep into our nighttime activities. So working around the clock can really have an impact on our ability to get enough sleep. Jet lag, anyone who's been over to Europe, if you've been recently, I'm very envious, will know that changing time zones can really disturb our sleep. The other one is, we touch on alcohol, for example, but it's not just alcohol in late in the evening that can disturb our sleep. There is some evidence that having food and drink too close to bed can actually disrupt our ability to get off to sleep as well. The other ones on here, stress I've touched on a little bit. Not making time to wind down to actually be ready for sleep is a big one. But a whole range of other factors can impact our sleep, such as sleep disorders, including things like insomnia and sleep apnea, and restless leg syndrome. But in the context of this audience in particular as well, other medical conditions, we know that pain can really affect our ability to get to sleep and stay asleep, even when we're really tired. The other one is drug side effects. I personally find that if I need doses of steroids for a period of time, I absolutely cannot take them in the evening because I struggle horribly with my sleep as a consequence. So having the conversation with treating doctors about medications and when to take them and how they might disrupt your sleep can actually be, for some people, a really useful conversation to have. So there's some sort of broad reasons why people sort of don't get enough sleep. I always like to add this one in a little bit as well, because we know that, work and sleep can actually be a pretty complicated duo. We do fit a lot into our days. And if you're somebody that works really stressful or worrying work, or there's, really high paced and, you're on a lot of the time, if you're working really long hours, then that can affect the quality of sleep we get at night too, as can working early in the evening and night. So the use of technology and bright screens, there's some kind of mixed feelings about, the impact of light on our sleep. So we know that light broadly absolutely can affect our internal clock and sort of disrupt things. We know that that's one factor that contributes to not getting enough sleep. But when it comes to using technology at night and blue light and exposure to light in the evening, one of the things we do know is it's quite complex. So we're all different in how sensitive we actually are to light. So one of the concerns with light at night, particularly in your houses in the evening, is that light suppresses melatonin, which is one of the hormones we know is related to sleep at night. And so for some people, even really dim light, so having the dimmers down, can actually suppress their melatonin, and they can report having difficulties sleeping. Whereas for other people, they can have the lights turned right up, doesn't seem to have as much of an impact on their bodies. So that's some pretty cool research that's actually come out of Australian group over at Monash University, and has made us really think about how different every individual actually is in terms of how much light at night can impact you. Broadly though, the best advice we can get in terms of our light exposure is if the sun's gone down, then our bodies need the light to go down too. We got very clever during the Industrial Revolution, and we're able to light up the night. We have electricity in our homes. I'm sitting here in very bright fluorescent light in my office and it's dark outside. And the reality is dimming the light that you're exposed to at night can be one of the really important things that we do in the evening. Certainly in our house at night, once the sun goes down, we start to dim the lights as we get ready for bed. It doesn't mean you have to sit in complete darkness, but it can be a really easy strategy to start getting things ready for bed and reducing the impact of really bright light on you in the evening. So I think I've covered more of these in terms of these aspects. The other thing that we do know though is that when we're sitting inside, even though the lights in my office are quite bright, broadly speaking, we know that the light that we get during the day, if we're in an office building, for example, all day, is actually dimmer and less good quality than the natural light that we need outside. So making sure that you get outside and get exposed to lovely, healthy, bright light during the day can be a really important thing for our health and for our sleep. Can we do anything about it? So these are just some general sort of sleep habit components. Some bits of this we do when we work with people that live with insomnia and they start treatment. We actually get pretty strict on some of this stuff, but they are all things that we can take away from this more broadly. So, broadly the rule when it comes to the bedroom is for sleep and sex and nothing else. And with the current technology kind of landscape, we do see a lot of iPhones and tablets in the bedroom, and they can be problematic, not just because they're alerting, but also because the content that we're watching on them can actually keep us awake more too. Light in the bedroom, we want those bedrooms cool, calm and quiet. So some people use blackout curtains. The darker and more peaceful you can make that bedroom, the better. For people that clock watch, if you find yourself lying in bed, just staring at the clock, worrying about how much sleep you haven't got at night, turning the clock around, or even keeping your iPhone, your tech out of the bedroom. Certainly for kids, it's a really great habit to get into from really early on in life, is just take the tech right out of the bedroom so that it's not able to be a disruption or a distractor. There are a whole range of other things that can disturb our sleep, and I certainly can't cover them all in our brief time tonight, but there are some great advice and great tips about broadly looking at things in the bedroom that you can access through the Sleep Health Foundation. And they're great. There are so many fact sheets on there, and some of them are more specific to particular sleep complaints too. So I'd really encourage you to have a look. But what I wanted to very quickly touch on in a little bit more detail tonight is insomnia. And insomnia disorder is something I wanted to go through because we do see sleep complaints that do align with insomnia diagnoses in patients living with pain and also with patients particularly with arthritis. So what are we talking about when we talk about insomnia? So for people that are living with chronic symptoms of poor sleep, so it can be one or multiple of difficulty falling asleep, waking a lot during the night, or waking up really early in the morning and having trouble getting back to sleep 3 or more times a week, coupled with daytime symptoms. And when I mentioned at the start about poor sleep looking different for everybody, this is what I meant. For some people, we talk about having absolutely no interest, for example, in the things they used to enjoy doing, or no pleasure in the things they used to enjoy doing. or feeling really down, depressed, or hopeless. Whereas other people can actually exhibit symptoms of being really hyperactive, impulsive, or aggressive, or really irritable or moody. So what those daytime symptoms actually look like of poor sleep can vary from person to person. But it's highly likely that you're familiar with your own daytime symptoms, feeling very fatigued, more so than perhaps even than normal with your health, impacts on your memory or your ability to concentrate on things at work or in your personal life, or even just having no motivation or energy to do the things that you like doing. So even if it's things like going to work or enjoyable, I enjoy going to work. But if it's also your hobbies and things like that, they're what we're looking for when we actually talk to people about chronic problems that look like insomnia. And one of the things that we do know, and I'm going to show you a graph which is a little bit more detailed, but I'll talk you through it, is that we know that people living with arthritis do have higher rates of insomnia than the general population. So this is from a paper that was published a little while ago now by Louis and colleagues. But basically what it's showing us, these yellow bars that I've highlighted are the proportion or the percentage of people in the community with arthritis that have or meet criteria for insomnia. So this box here is insomnia. What it's showing us is that, unsurprisingly, people that have chronic health conditions do seem to have more difficulty with things like insomnia. So this is true for people with arthritis. And in this comparison, they've also got people with diabetes, asthma, hypertension, cardiac conditions, and upper gastrointestinal complaints. So we also see this in terms of excessive daytime sleepiness. It looks pretty comparable. It's not actually that much higher. But the one thing I did want to show you is also that, it doesn't necessarily look like they're getting less sleep. And that stands up with what we see with people with insomnia. It's not necessarily that they're getting less sleep. It's that the quality of the sleep they're getting isn't what they would like it to be. And also they're not necessarily sleepy, but they're feeling really, really fatigued. And so for comparison I pop this little comparison up. So this is how common insomnia is, using some different definitions just in the general population. So that middle one is that these are two different diagnostic criteria for insomnia, the global map and the checklist. And what they're telling us is that about 14% of the population have got symptoms that would suggest they have insomnia disorder. Only 7.5% of people actually report that they've got a diagnosis. So what we know is it's probably only half of the people that meet criteria actually have a diagnosis of insomnia, even if they meet those criteria. And that this is lower than what we see in people with arthritis, where that prevalence is getting closer to sort of 23%, so 1 in 4. And for some of you potentially that do live with arthritis and have trouble with your sleep, you're probably aware of this and nodding along. But there's kind of two takeaways from this, and something that we talk about with insomnia patients more broadly is, insomnia can feel really isolating. You can feel like you're the only person awake at night and everyone else is sleeping well. And the reality is it's actually a lot more common than people might think. So there's a range of things that we do. And the interesting thing, the thing that can sometimes be a bit surprising, is that the gold standard treatment for insomnia, the treatment that does sort of produces the best outcomes, is actually something called cognitive behavioral therapy for insomnia. So it's usually administered by sleep psychologists, and it's more effective than sleep medications in the long term. So it seems to do more and have a more sustained effect than using sleeping medications, which can be really reassuring for people who really don't want to add more medications to their list of treatment options. So this is a very high level summary because we only have a short period of time together. But I think it's really important to point out that some of these strategies, it usually happens over 6 to 8 weeks of treatment, can be really effective in improving insomnia in patients that present with these complaints. So we do some really detailed sort of work on looking at the bedroom environment and some of those behaviours I talked about that happen in the bedroom or just before bed, to try and improve, get everything right. You want to try and line everything up so that by the time you're ready to go to bed, you're feeling just the right amount of sleepiness, or what we call sleep pressure, and it's happening at the right time so that when you get into bed, you're able to get off to sleep. We also do a range of activities with some people which involve, we see that when you spend a lot of time in bed awake, you're teaching your body that, the bedroom is not for sleep, it's for lying there awake. And that association can really settle in and make it challenging to change your sleep behaviors in your bedroom. So we do a lot of things that involve getting people to actually get up when they wake up and leave the bedroom and come back when they're sleepy, so that, again, we're reacquainting our body with sleeping in the bedroom rather than lying there wishing we were asleep. One of the main parts of cognitive behavioral therapy for insomnia is something that we call, is listed here as sleep restriction, but we call bedtime restriction therapy. So we actually reduce the amount of time that you spend in bed, so that you increase the amount of time that you're in bed asleep. And it's a bit of an interesting one and can sound counterintuitive, but is extremely effective for improving people feeling sleepy before bed and actually getting more sleep when they're in bed for the same amount of time that they're reporting they were actually sleeping before they started treatment. And then there's a range of other activities, such as relaxation activities, meditation, cognitive strategies, so actually rethinking what we do and don't know about sleep and trying to get rid of some of those more unhealthy thoughts and patterns to do with sleep are all part of the treatment approach. And then we ideally give people the tools that they're able to take care of this themselves. They've got enough information that moving forward, if they do have disruptions to their sleep, it's something that they can take care of, independently, rather than having to necessarily rely on having to go through the treatment approach again. So the big question being, does it work for people with arthritis? And the simple sort of take home is yes, it does. So there's a lot of information on these slides. I'm really aware of it, but I wanted to put this up here, I guess, as some reassurance. These are randomized controlled trials, which are really important tools for understanding whether a treatment works or not, compared to what we call a control condition. And in both of these examples, these are only two, there are more. What we actually see is that cognitive behavioral therapy for insomnia can reduce the time, that wake after sleep onset, that time lying in bed wishing you're asleep when you're awake. It can actually improve pain intensity. So that's another benefit that we do sometimes see for patients living with insomnia and chronic pain conditions, is there can be some benefit for pain symptoms. And we also saw in that first example that patients with better sleep, so those that were waking less at night, were the ones that actually had better improvement in their pain scores when they were followed up. And in the second study, and my references haven't come up on here, I'm sorry, I'll make sure I add them in for you, Ben, before you put it on, before you use the webinar online. But what we also see is that when patients with rheumatoid arthritis have insomnia, and this was actually group-based cognitive behavioral therapy for insomnia, which some nurses led, it improved their insomnia symptoms to the point where they didn't meet diagnostic criteria anymore. Improved perceived impact of the condition on their life, which is a huge consideration when you're living with a chronic condition. Improved depressive symptoms and the experience of fatigue, and also meant they had better or less pain at 26 weeks after they'd had the cognitive behavioral therapy for insomnia, which was really positive. So the take-homes in terms of when and how to get sleep are really important. I'm a really strong proponent for, and there's probably a whole bunch of GPs now out in the community wondering why everyone's doing this, but I think sleep should be a part of the conversation you have with your GP every time. If you're not sleeping well, we know that sleep has knock-on effects for mental health and for physical health. So if you're sleeping poorly, it's definitely something to be chatting to your GP or your specialists about. We know that sleep problems are really not uncommon in the population, and they do seem to be more common in people living with arthritis, particularly when you're trying to manage active pain and trying to sleep through that too, which can be really challenging. The other sort of scary statistic for us, if you like, is that 42% of the middle-aged population have got a sleep disorder that could probably benefit from intervention. So that's things like insomnia, obstructive sleep apnea, and restless leg syndrome. And that's a lot to consider. So there's two ways of looking at that. It's a pretty high number, but there's also some things we can do about it. We know there are treatments if we can get people talking about their sleep and reaching out to people about their sleep. So I have focused quite a lot today on insomnia. It's a bit of a big ask to talk about lots of different sleep conditions. I didn't want to sort of give you a laundry list, but there are a range of other sleep disorders in the community which can disturb your sleep. So if you are snoring, if you're feeling super sleepy, even after, feeling like you've been asleep for a long time, if you are having trouble getting to or staying asleep, they're really important things to talk to about with your healthcare providers. And the last one being, they're not necessarily as well known in the community, but sleep psychologists can deliver that first line treatment for insomnia. There's not a lot of sleep psychologists in Australia, but there are enough that you can find them, and there are referral options for them. And one thing that is less well known is actually that insomnia by itself can be a referral reason for a mental health care plan to a psychologist for treatment, which can actually help with out-of-pocket costs too. There's also a whole bunch of resources that are available to you through places like the Sleep Health Foundation, which are a sleep advocacy group. They've got very specific references about pain and sleep and about how that relationship, it certainly goes both ways. We know pain can disturb sleep, but we also know that getting poor sleep can exacerbate the experience of pain or the ability to cope and manage when we are living with pain. And similarly, there's some great insights there into insomnia too. So Ben, I'm very happy we can put some live links on that for people if that's useful. But even if you just Google Australia Sleep Health Foundation, you'll be able to find those resources really easily. So I'm mindful of the time, but I think we might leave it there for today, Ben, because there's usually a bunch of questions about sleep stuff, and I'm more than happy to answer the ones that I'm able to within my own area. Sleep is a very big field, so some I may not have the knowledge to answer, but I'm very happy to speak to what I do know.
Perfect. Thank you so much for that, Amy. That was really informative and really, really good. I'm going to kick off one that we get asked a lot. I can say that from a lot of our talks. Is it possible, could you briefly go over about naps? Because we know lots of people have lots of different opinions on them, and some people, view it as time to catch up sleep and things like that. What's the science around those?
Absolutely. So naps, the science around naps, or how you feel about naps, or what your treating professional tells you about naps, will differ depending on how good your sleep is at night. So if you're somebody that's waking up a lot during the night and having trouble with insomnia symptoms during the night, then naps after lunchtime can actually be really tricky. And what they do is they take away that what we call sleep pressure. And so, in that case, what it does is if we, for example, have a nap at 4 o'clock in the afternoon, it takes the edge off of that sleep pressure that we need to fall asleep in the evening. So it can feel really, really good. I'm a napper on the weekends, but I am really careful about when I have them and how they impact my nighttime sleep opportunities. So that can be why sometimes, and certainly when we talk about treatment for insomnia, and part of that cognitive behavioral therapy for insomnia is we talk about the naps. One of the things that you can do is shift the timing of the naps and the duration and make them a little bit shorter. So if, sometimes if people are particularly struggling with feeling sleepy, they can have just a brief nap around lunchtime. So naps are not necessarily evil. In fact, they can be really important, and particularly for people, for example, that work shifts. If you're able to nap before a night shift, then that's absolutely an important strategy. But also it's about where and how you nap as well. So certainly with patients that come that I have met that have chronic pain, resting is important, particularly if they're feeling fatigued. Resting can be really important. So we often talk about where they rest and, what that looks like, rather than necessarily having long naps in the bedroom and then feeling like they're awake all night as well.
Perfect. Thank you for that, Amy. Another thing that I'd kind of raise is, and it's one of the things that we talk about, is that kind of having that conversation for someone having that first conversation with, say, their GP around their sleep. Do
Yeah.
you have some tips to prepare that? Like, are there some things that people should do in the lead up to around that?
Look, I think if you just saying I'm not satisfied with my sleep and being aware of which bits you're not satisfied with is a really good prompt to start the conversation. I think if you're wanting to be able to talk to the doctor a little bit more about why you think your sleep is a problem, you can keep a record of a week's sleep, handy. You can keep, write that down before you go to the doctor so that you're really clear on which bits you're unsatisfied with. Keeping a bit of a record of what your sleep looks like over a week can be really helpful. And in fact, sleep diaries are something that we do use as part of cognitive behavioral therapy for insomnia, because it is about the individual's experience of that. So yeah, that is absolutely something that, that you can do in advance. But I think on the most straightforward of levels, saying I'm really not happy with my sleep, or I'm feeling fatigued, or I'm feeling sleepy, or I'm waking up too much during the night, or my partner's telling me I'm snoring or I'm stopping breathing at night, start with how it's feeling for you. That's the really important part.
Perfect. Thank you for that, Amy. Someone's written a question about mattresses, and they're asking about if there's specific mattresses that work better for people, kind of split into two questions, and then ideas about positioning, or then if like air mattresses such as are used in hospitals, are they better, or is there specific ones that might be better for people?
That's a really good question, and I don't have a clear, specific answer when it comes to mattresses. Comfort is important, obviously. But in terms of positioning, that's a really interesting question. I'm glad you brought that up. So what we do know is that for some people that live with obstructive sleep apnea, for example, they can actually experience worse symptoms if they're lying flat on their back, because we see this kind of pressure on the airway, and it actually can place more pressure and obstruct the airway more as well. And so actually what the research suggests is that for some people, those symptoms of sleep apnea, so some of that snoring and sort of that closure of the airway, one of the treatment options is actually getting people off of their back and onto their side so that their airway is able to stay more open. And that can really help for some people. And it's something that sleep physicians can speak to patients with sleep apnea about. So that's kind of one instance, I guess, where positioning can be really important.
Someone's asking, why does it seem that their arthritic pain, such as in the hips, gets worse while they're sleeping? Can you comment on that?
Yeah, look, I mean, I guess there's probably a range of reasons. I'm certainly not going to suggest that I have all of the answers there, but lying in one position, potentially can be uncomfortable, and that's certainly what some patients say can be particularly, uncomfortable. It may also be to do with the time of day. There seems to be different time of day effects on some symptoms of pain as well. So related to that timing, but particularly if you're not moving around a lot in bed as well, that potentially can make it more uncomfortable.
Perfect. I mean, follow on from that, is there any if people do have kind of that chronic pain around arthritis and things, and possibly building those sleep routines, are there any specific, and I mean it's a case by case basis, are there things that people could help do to maybe alleviate that pain before trying to get to sleep?
Yeah, look, I think I don't know specifics, and you're right. It actually is going to depend a little bit, I suspect, on where people are, what the cause of the pain is and how people are feeling about it. But being aware of some of the triggers for them that might be particularly uncomfortable, or some of the things they do in the evening that are more or less uncomfortable, where they time their bedtime routine, and when they time exercise, for example, if exercise helps, then maybe that's something that they can consider doing early in the evening to be more comfortable. Or if it makes it more uncomfortable, moving those kind of less comfortable activities to outside of the time before the sleep window potentially could be beneficial. So we would typically when talking to patients with chronic pain in a cognitive behavioral therapy sort of environment, we would think more about the individual and which aspects of their lifestyle were on a case by case basis impacting their sleep.
Perfect. Well, I'd like to just thank you so much for your time, Amy. It's amazing to have such an expert on such a complicated field really break it down into such an easy to understand way. Um, Before we leave, is there anything you'd like to wrap up with, or?
Oh, look, other than to say, look, it's really lovely to be able to talk to this audience in particular. Being somebody that, pain absolutely impacts my sleep, depending on how my health goes. And I have a great deal of empathy for people that are in a similar boat. So I've really enjoyed the opportunity to share a little bit more about sleep. And would absolutely encourage people to have those conversations. It can easily fall down the priority list, but it really can make a huge difference for some people if managing those, particularly those insomnia symptoms and, unmanaged sleep apnea can help.